The next section is about the MIC. We heard already the personalized medicine approach, treating, of course, patients, but looking for mutations. And now we are coming back to the role of MICs in optimizing TB treatment by Connie and Mary Claire. Please take it away.
Okay, here we are towards the last session, and we are going to talk about MICs. So our first patient is a 49-year-old female nurse, immigrated from Moldova about a year ago. She has aggressive cervical cancer that she's been treated for, and she has lymph node metastases. In April of 2019, she completed cisplatin and radiation therapy, and she'd had good response. She started adjuvant chemotherapy, was being followed with serial CT scans. CT scan from about 4 months later showed increased right upper lobe nodule compared to the March scan at the beginning of her treatment. She underwent an FNA and core biopsy of that lung nodule, and they were surprised to see that there was necrotizing granulomatous inflammation with numerous AFB, and it was positive for MTB. And of course, they had thought that she probably had a recurrence of her cancer, so it was somewhat of a surprise. Her chemotherapy was held, and she was referred to the local health department. The patient was clinically asymptomatic and HIV negative. She had no prior TB or LTBI treatment. Her sputum was AFB smear and NAT negative, and cultures pending. And so based on the information we had, the providers had at the time, she was started on RIPE. A few months later, the biopsy specimen grew AFB in culture, and we were very glad that actually sent it for culture instead of putting it all in fixative. And it was identified as MTB molecular probe. Unfortunately, there was no immediate access to a gene expert, and so there was a bit of a delay. And it wasn't until next month that the isolate was sent on an LJ slant to the jurisdictional public health lab. And, within the day of getting it, the gene expert was performed and indeed confirmed that there was MTB, but also rifampin resistance. At that point, the isolate was immediately sent to CDC so that an MDDR could be done. And as I mentioned, the faster the sample gets to the lab, the faster you're going to get your results. In Florida or at the SNTC region, we like to send samples to different labs. So we will always send to the CDC, and because we have Marie Claire and her team, we were able to also send it down to the Florida State Public Health Lab. But my recommendation would just be send it to CDC, but if there's another lab where you'd like to send it, whether it's National Jewish or Southern California, New York, our lab in Florida, we're happy to help you, but send it for a second. It's just good to have results confirmed. And sometimes different results come back at different times, and you never know which lab is going to have a little bit of a challenge. So soon after we had the gene expert, we were able to stop rifampin therapy. And fortunately, CDC quickly got back the MDDR report. And Marie Claire, would you like to just read through this for us?
I should probably have Angela do that.
Oh, well, that's true.
But you can see here there was an RPOB mutation, the interpretation rifampin resistant, CATG, isoniazid resistant, PNCA, possible pyrazinamide resistance, GYRA, possible fluoroquinolone resistance, and EIS, possible resistance to some of your injectables. So that's a lot of mutations.
It is a lot of mutations. And remember, this woman was from Eastern Europe. And so the TB was a surprise, but that was even more of a surprise, quite unfortunate. And so then we sent down, as I mentioned, we concurrently sent the isolate to places. And so we also received results back from the Florida Department of Health lab. So would you like to kind of talk through these and what you're seeing?
Essentially in concordance with the MDDR results that came back, you can see highlighted an RPOB mutation, a CATG mutation, PNCA, EMBB, GYRA/B, and then EIS. So it's basically in line with what MDDR said. They do a lot of sequencing methods there. We did a combination of the Hein line probe assay and DNA sequencing. And then, so the hindline probe assay is twofold. There's one, the MTBDR+, which is looking at RIF and INH resistance. And then if we see resistance there, we reflex to the Hein MTBDR-SL, which is essentially those second line drugs, which is fluoroquinolones and injectables. And then, like I said, we kind of supplement it with DNA sequencing. And in addition to that, we do some more sequencing for looking at for resistance to bedaquiline and linezolid. And I will say we use that in a research use only capacity. This is only reported to the TB public health program and really used for our public health purposes. It doesn't go onto the patient's report. But it's just, you know, a sort of another tool in the toolbox for the TB program and the TB physicians to use. Back to you, Connie.
Well, I just want to clarify too, when we say research use only, that doesn't mean that, you know, it goes off to research lab and we get the results back later. We get these results in real time, you know, the same time that we get back, you know, the full, the Hein and the Hein SL. And so usually it's within days, you know, we'll get if we can test a sample on Tuesday for the Hein MDR+, and then on Thursday, they'll run the Hein SL. And then on, you know, by Saturday, we typically have, Friday or Saturday, we typically have the full sequencing. And so it really is a matter of days. So as soon as the lab gets the sample, treatment or I'm sorry, appropriate testing can be done, and then the appropriate treatment can be started. So this patient was asymptomatic. She had focal paucibacillary TB disease because her only site of disease was a single nodule. Well, the only clinically manifest site of disease. Her sputum, as I mentioned, was AFB smear negative, NAT negative, culture negative. And so that was the only sample we had to work on. But it was clear by the molecular drug susceptibility that we had at this point. She had XDR-TB. She was resistant to INH and rifampin. She was resistant to at least one quinolone and at least one injectable. And so, goodness, this was really, really concerning. We had to figure out how to treat this patient. And so we needed more information. And this is what we got back in terms of growth-based drug susceptibilities from the local state public health lab where the patient was being managed. So Marie-Claire, do you want to comment on this?
Yeah, just briefly to say that that jurisdictional public health lab did susceptibility testing by midget, looking at critical concentrations. With midget testing, this is usually done for the first line drugs. So you just see those ripe drugs here that were tested, and you can see they found resistance in INH, rifampin, and PZA, which was not unexpected.
All right, and then the phenotypic drug susceptibility results came back from CDC. And so do you want to talk about this, and then we'll talk about the other testing that was done?
Yeah, and I think this really, again, was pretty concordant with what you already knew. But as you were saying, you know, some labs do look at different drugs or look at them in a slightly different way. So it's always useful to have that additional information. I mean, of course, with the initial lab, they only looked at the first line drugs, whereas you can see a much broader range of drugs that were tested at CDC. But, you know, again, and we'll go more into this in this talk because it's about MIC, but these drugs were all tested by a critical concentration method. And so, you know, the clinical questions that, you know, I was having, if, you know, we have to figure out how to treat this patient, you know, we know based on, you know, the critical concentrations that there's, you know, the same resistance, INH, at 5, rifampin at 1, you know, it looks like there's, you know, pretty high resistance at rifabutin, perhaps quinolones. And so it was really a question that we, as a provider, you want to know, you know, can I increase the dose of rifampin or even use rifabutin to overcome resistance? These are, again, some of the things we talked about with our other cases. You know, is high dose INH a possibility? Are all injectables equally resistant? Can the quinolone resistance be overcome? And then, you know, what is the susceptibility of bedaquiline that was not being done by critical concentrations? That capability does not exist to my understanding. Is that correct, Marie-Claire, that there is no critical concentration for bedaquiline at this point? Yeah, and I mean, there just really haven't been enough clinical outcome studies to determine that. at this time.
And, the other thing, and as I mentioned, we do use a lot of linezolid in our region, and based on the level of linezolid resistance, is there a safer lower dose that we could use and still effectively kill tuberculosis? Because I think by now, people have heard linezolid, can certainly be toxic. And, it's definitely a concern when you're managing a patient. You want to, above all, cure the patient, but cure them safely and make sure that there's no harm. So would you compare for us the methods of growth-based detection of drug resistance?
Yeah, and I think really this is just to say in a nutshell that with critical concentration, essentially you are only evaluating, for the most part, one level of the drug and looking at whether the organism is susceptible or resistant at that drug level. And when we're talking about minimum inhibitory concentration, obviously we're looking at multiple concentrations of the drug, usually doubling dilutions. So you're really, you have the ability to look at the distribution of resistance along that gradient, as opposed to only looking at a single time point or a single point. And this is just, picture to make, break up some of the words. But, on the left-hand side, you see a Bactec midget, which is what most labs in the US and use for culture of mycobacteria and used for the liquid growth-based susceptibility testing. And on the right-hand side, you see the equipment for SensiTiter MIC, which is a very different setup in that you're using a microtiter 96 well plate, and all of your dilutions are done within that plate. And here is a map of what that looks like. And I think really just to point out here that we are looking at 12 different drugs when we do this 96 well plate, and all of those 12 drugs are run obviously at the same time. You run a whole plate for one organism, and it kind of goes back to that initial slide where we looked at midgets, but that's when most people do midget susceptibility testing, they're only doing the first line drugs, and then if they see resistance, then second line drugs, there's a reflex to that. And I think this is one of the advantages here, is that you get all 12 results for these drugs at one time. And just overlaid this with what an actual 96 well plate looks like. If you can advance again. I don't know if it's possible to use my arrows, but hopefully the red ovals will highlight to you where you can see those little buttons. That is where you actually see growth of organism. And the one that Connie's pointing to now, yes, is rifampin. So you can see there is growth in every well, all the way up to 16 micrograms per mil. If we move over to, did you want to talk about streptomycin?
I was just showing that as a cutoff, that there's some growth there, but perhaps not.
Right. And then you move over again, you can see rifabutin there. It's all the way up to 2 micrograms per mil. And then moving over, you can see INH all the way up to 2. And so this is just to show you an example. If you click again, to show you an example of what an MDR TB might look like on an MIC plate.
Great. So what are, you've mentioned a few things, certainly that you can test 12 different drugs at once. And, one thing that you and I've talked a lot about, because we've been trying to decide how do we want to customize ours. We, as a practice team, Dr. Ashkin, myself, Dr. Lizardo are talking about, what drugs are we using when we're treating patients with drug-resistant tuberculosis? And, there's even new options now. And so we're talking about, to be able to use MICs clinically, we need to make sure that we're getting the right drugs on the plates and that we're not testing for drugs that we're probably not going to use anymore. We've talked about whether it's even worth testing for aminoglycosides, when we have so many other things that we might consider. So do you want to talk a little more about some of the advantages of using MIC?
Yeah, and just to carry on what you said about the ability to customize, we've actually been doing MIC in Florida since 2013. Now, we started out with a standard plate from the manufacturer, But, you know, at that time it had afloxacin on it. And it kind of goes back to that thing where the TB program, the TB medical director, SNTC, this conversation, well, do we really need afloxacin on the plate? Well, we're not really using it. It would be great to have levo, you know, so we're able to take some of those drugs off and add some on. 2017, we added linezolid to our plate. And of course, this isn't without its challenges, and we'll get into that a bit, but, you know, because this is a lab developed test, we've got to validate it in the lab. But just to highlight that is an advantage, this ability to customize, that you do get 12 drugs. And as you know, things change. I mean, we think about EPAL and the changes that will force us to do to look for resistance with the drugs that are actually being used to treat TB patients. So it goes to this ability to tailor what you're doing.
Yeah, and then for me clinically, you know, as I was mentioning earlier, you know, can I get a high enough dose in the patient over the MIC where I don't run into the toxic, you know, the toxicity that occurs? You know, if I have a drug like linezolid, we typically use MICs. You know, we try to use the most effective dose we can, but if the patient has side effects, or where we know that, you know, using doses as high as 1,200 milligrams, you know, has been shown in the next trial to be toxic, then we want to try to use the lower dose, and we feel much better knowing that the MICs are quite low, and that even at a 600 milligram dose, if we can keep our range, you know, 12 to 26, you know, using therapeutic drug monitoring, then we are well over the MIC of 0.12, 0.25, et cetera. So it's really helpful with drugs that have a narrow therapeutic window. Anything else here about advantages that you want to mention? Or, I don't know, Angela wants to wait and comment at the end, but.
Yeah, I mean, I will just say, I mean, there was the conversation earlier about using rifabutin, and I just think having that additional information immediately when you got 12 drugs reported out, where you would have a rifampin MIC, you would have a rifabutin MIC, that can be really helpful. And then I said there about comparing phenotypic to genotypic susceptibility. It's also helpful to have an MIC. And one example, a great example, would be like with low-level rifampin resistance. You see this genotypic mutation that's associated with low-level rifampin resistance, but then it's really useful to actually have the MIC. Now, if you had a critical concentration, it would probably just say susceptible. But for us, from the MIC standpoint, we can see, okay, well, yes, it's susceptible, but we can see that the MIC is elevated. So I think that's, you know, having that little extra piece of information can be crucial for the clinician when it comes to treatment.
Yeah, I think you'd feel a lot more compelled to try higher dose if you knew that, you know, you needed to push it up a little bit. And it, you know, of course, depends on the drug, whether the drugs you're going to reach toxicity earlier, or if, like with rifampin, and here's a nod to Chuck, you know, you could use much higher doses of rifamycin without getting into toxicity. You know, what about when MIC breakpoints aren't established? Which drugs are those?
Yeah, I mean, we have several drugs which we don't have established breakpoints for it, and there's no guidance from the manufacturer. I mean, linezolid's a good example. But usually, I mean, we're able to see the MICs, and the clinicians have experience with looking at those and are able to interpret that information clinically. I think this kind of goes on to the next point about community surveillance. It's really interesting to look at the MICs of these drugs over time, because most pan-susceptible TB cases would never get a linezolid MIC or a levofloxacin MIC, because they'd only get the first-line drugs tested and not the rest. And so it's kind of been interesting for us in Florida to look at all of our TB data over time and just generally look at MICs and look at susceptibility to a variety of different drugs.
Yeah, and you know, I mentioned earlier that we do, you know, I do ask sometimes to go ahead and do molecular testing, even when there's INH and rifampin susceptibility. It's for the quinolones, just because of how frequently they're used in clinical practice. Some of the studies that have shown that doesn't take that many days of treatment with a quinolone in a patient who has undiagnosed TB to develop resistance. And so, it does help if you're going to have an INH resistant patient who has to rely on a quinolone, as the second drug in partnership with the rifamycin, or if you have another scenario where the patient has lots of intolerances and you've got to substitute out, the quinolone or even linezolid, I'm very happy to know that I can call you and say, hey, I'm having to rely on this in my treatment plan. What do you, am I good? And you can let me know. I mean, linezolid resistance is very uncommon, but for quinolones, I would say it's a lot more important for me. What about the challenges? We've talked a lot about non-FDA approved things and things that are lab developed tests. Maybe you could just say one more time, like, you're reporting out to us clinically the information so we can make a clinical judgment, but I mean, lab developed test or non-FDA authorized method does not mean that there's no value or that it cannot help guide clinical decisions.
Well, to talk about the FDA issue, I think it really comes down to what are the expertise, experience, and resources at a lab. And I think we all completely appreciate that not every lab is going to have the resources to be able to bring on a lab developed test. That's just the reality. And TB testing does bring with it unique challenges related to the lab and the testing that can be done. So, I mean, I think it's great if a lab can do these off-label tests, if they are able to validate them as lab-developed tests. But I think obviously the expectation is there are only going to probably be a handful of labs that have the capability to do this. So that does present challenges for MIC. Another thing
about that would just be the issue of CLIA approval. I mean, any lab could potentially develop a test, but how do you know that it's a good quality and that that's really something? How do you know your lab's LDT is really something that you can rely on?
I mean, you obviously could always look at the data that they used to validate that test, and that's often, when a new test comes out that is a lab developed test, that data will be provided with the actual result. This is based on 200 whatever. So for example, in Florida, we actually compared MIC to the Bactec 460 on the drugs that we could, back in 2012-13, to bring this lab developed test on board. So one thing would be looking at the data. Two would be, just in general, looking at the reliability of that lab, the reputation of that lab, and not just for that testing, but other testing that it does. So those would certainly be things to look at. But I would say, most of, I would say all of our jurisdictional public health labs, adhere to the clear regulations and do a great job.
Yeah. If I may, Connie,
yes,
if you could
wrap
up, since we already passed in a way the time slot, but we still have a few minutes.
Yeah, and then I'll just wrap this up. So of course we can get discordance between genotypic and phenotypic tests, or between two phenotypic tests. And I think we've talked about that already today. There is a slightly longer turnaround for MIC versus the midget critical concentration method, but I think the advantages outweigh that disadvantage. Connie?
Yeah. Thank you. So I'll just, finish up. The patient initiated what we considered a bridging regimen while we're waiting for more data: bedaquiline, linezolid, cycloserine, clofazimine, ethambutol, plus moxifloxacin. And we were concerned about ethambutol because she'd been on RIPE with mutations in all three of the other drugs that she was taking, sort of unopposed. And so she tolerated that well, but with patient input, she actually turned out being the first patient that we treated with VPAL, and it really seemed like the best first case scenario for us. We did get back our MICs for her, and the MIC for INH was indeed quite high, concordant with the molecular testing. The rifampin was also quite high. EMB was susceptible, but I really, we didn't consider, we weren't able to get another specimen after she'd had RIPE before she started VPAL or anything else, because it was a biopsy and not, she was sputum negative. But the rifampin was susceptible, but by the time we got back the MICs, she was already on treatment with VPAL and doing quite well. But This is just to kind of give you an example of what some of these look like. The thing that was really important to us was that her linezolid MIC was really very low, 0.12. And that helped us when we were adding that into therapeutic drug monitoring. And I'll just draw your attention down to this darker side. If you are interested, these data are published in EID, and I'll give you the reference in a minute, but her initial therapeutic drug monitoring wasn't done exactly as a trough, which is usually at least 24 hours post-dose. It was a little higher, a little earlier, but her trough was still quite low. And so, the peak was in a good range. Probably she was peaking even higher between the 2 and 6 hours. And with the low MIC, we felt very comfortable that we could decrease her linezolid dose from 600 milligrams daily to 600 milligrams Monday, Wednesday, Friday. And indeed, we repeated our drug levels 2 weeks later, had an appropriate trough. We still had a nice linezolid dose in the therapeutic range for this patient, and she was still well over 4 to 16 times the MIC. And so if you want to get therapeutic drug monitoring levels, it can be done at the University of Florida or at National Jewish Medical Center. I'm glad to say this patient completed 6 months of BPAL. She's been disease-free for over a year, likely cured, but we're going to continue to monitor her closely for at least 2 years. And here's the reference I mentioned if you wanted more details. So I think with that, we are done with our presentation. And I don't have the question screen popped up, but if we have a moment for questions, Max, I'm sure Marie-Claire and myself would be glad to. I do want to provide y'all the links to the Centers of Excellence and each one of the individual sites. And I had one more slide, but I guess this is what I wanted to show. Max, were there any questions, or would you like to wrap us up, or would you like me to?
There was one question from Randall, respectively, a comment, and he says, I believe we saw rifabutin toxicity, uveitis, using higher dose rifabutin in AIDS patients with disseminated MAC. Levels pushed up by Clary interaction, perhaps.
Yeah, thank you for that comment. I think, again, that goes with, sort of the theme of the day, which is that, clinical decisions plus lab decisions. You certainly cannot rely only on the fact that someone has a low MIC. You have to rely on your clinical judgment, your experience treating patients, and what you've read in published literature about potential toxicities. And so, I think having a low MIC is not necessarily mean you can just, or having a higher MIC is not necessarily, licensed to just push it up. So, hope that helps a little. Anything else? Any other questions? I believe, Max, that we will be posting this. We will post the slides, and I believe that we are going to try to also post the recording afterwards, and not just to the conference attendees, but also perhaps, since we are Centers of Excellence and what we do is open access, we are hoping we'll be able to post this on one or all of the COE sites. And so I want to definitely thank all of the speakers today. I'd like to thank Anita Cajal, who was with GTBI, and her team, who really put this whole conference together and did an amazing job. Everyone on the planning committee. I'd like to thank everyone at the NAR conference planning meeting and our technical support for making this a successful presentation. And I hope that our participants enjoyed it. And we're still could probably take a few questions in the chat or out loud if anyone would like to ask questions. We're over time though, so if you need to go, it's certainly understandable. Max, anything else for wrap up?
No, I think you hit all the important points.
Any of my other co-presenters would like to say something? Or Angela with the lab, any last CDC perspectives?
Just to say thank you for the opportunity to participate in this session. I learned some things, and hope others did as well. And just know that the laboratory community is always here to help, and feel free to communicate with us.
I second that. We're a resource for you, so feel free to reach out to us anytime in Florida. If I've already seen a couple of emails, so we'll look forward to communicating with you.
Oh, and I'd also like to remind you that the evaluation form is posted in the chat.